Welcome to the Cutting the Gordian Knot podcast. Today we're joined by Grace Marie Turner, the founder of the Galen Institute. She's been named as one of the top 24 people advising the White House on healthcare. Grace Marie, thanks so much for joining me. If you want to tell me a little bit about the institute you founded, that'd be wonderful, starting with why you chose Galen as the person you wanted to represent this new organization.
Thanks so much for having me on, Jake. I actually named it after the 2nd century Greek physician, who was a physician to, among many other things, the gladiators in the Roman Empire. And at the time, autopsies were strictly forbidden, but gladiators are always getting themselves sliced up. So he used that as an opportunity to learn more about anatomy. And he wrote prolifically about his medical findings and research. And his books are still in print today. So he's pretty much derided because he was considered as the guru, sort of the end all and do all about medical knowledge until really the 1800s. And finally, people started to realize, maybe there's some things he didn't get exactly right. Well, what do you know? Maybe after 16 centuries, you should have done some of your own research. So anyway, I named it after Galen because I think he really was a pioneer in healthcare and really started trying to push the boundaries and learn as much as possible. And I started it actually right after the Hillary Care debates in the 1990s. I had pulled together a group of our colleagues from the other free market think tanks who were completely being silenced in the debate because their ideas were considered to be not at all relevant. And I said, well, one of the reasons is that you guys are confusing members of Congress, that they, whether it's the AEI plan or the Cato plan or the Heritage plan, you guys are arguing about the details of your plans and not about sort of the central ideas of what brings them together. Well, that's boring. We all agree. What is it you all agree on? Well, consumers should be in charge. We need to have an actual market in the health sector like we do in other sectors of our economy. And we need to organize payment policies around that. Well, we all agree on that. Hello, members of Congress have no idea. So we got together, we put together a statement, did a news conference. We wound up doing another major sort of day-long conference on the Hill and a book. And the consensus group still meets today. In fact, we have a new project, a new product frequently, as well as meeting with members and trying to help them to get on the right track on health reform. And people say, oh, well, conservatives have no ideas in health reform. Totally not true. But we're always derided, that, your ideas can't possibly be right because you don't have a big enough role for government in your health sector. There is a role for government in the health sector, but we have way too much, right?
Awesome. Galen was also quite famously a philosopher.
That's right.
And it's funny that medicine for a very long time was actually grouped under philosophy, and for the interesting reason that they believed it was the art of justice within the body, that things received what they needed according to the principle of what they are and according to what perfects them. So it was grouped under philosophy, and we later get people like Avicenna, who kind of picks up after Galen as the big doctor of the world, and he's also still in print. But I think that's interesting that you've kind of brought this all together, because when we talk about economics, we're actually talking about justice. We're talking about inequality in prices, what you get and what you are paying, right? And we want to be able to match these things with a market, and that's why we're free market. That's why we care about health. That's why we care about philosophy. And, Plato and others talk about how justice is also the very core of the state. Where if you build a nation on injustice, it's going to fall apart and it's going to harm the common good. But if you build it on justice, on truth, on things like that, then you actually get a thriving society. So what we're, I think, going to talk about are ways that we can actually make things more fair. And we believe that involves just law, and that involves market prices, right? So conservatives certainly do have a lot to say about this. We've always had a lot to say about this. But we'll also get to some of the bad ideas that have been proposed. But let's kick it off with kind of what you mentioned. some things which were agreed upon by big free market think tanks. What are some suggestions which just have a broad level of agreement amongst free market advocates that could actually solve some problems in health?
Well, our latest project, we actually met with some members of Congress, and one of them said, "We don't want any more white papers. We don't read them. Why do you spend so much time writing those white papers? Just tell us what to say." So what we did was put together, it's basically a white paper, but it's pocket cards, just, okay, you want to talk about why we don't want to import the drug prices that the French pay. You want to talk about the risks of China taking over pharmaceutical research. You want to talk about what to do about Medicare and what to do about payment policy. We've bought a pocket card for that. So they're very well received, very well received. But anyway, so we try to also, I was a journalist early in my career. And so I always try to think about our audience, who is the audience? Who are you trying to reach? And what is the best vehicle to do that? Now, in talking with college professors, need very likely want a white paper. But when you're talking with a member of Congress, they need a pocket card because it's really otherwise too hard for them to sort of understand the deeper thoughts. And they're not going to get into that in a town hall meeting either because it'll put their audiences to sleep. So anyway, the ideas in this latest series of pocket cards are that we are never going to price control our way out of the problems in our health sector. Price controls have not worked for 4,000 years, despite the efforts of many, including in the current campaign, to talk about the value of price controls. Well, price controls are not going to work. And it's like Milton Friedman said, it's like having a pot of boiling water and it's about to boil over. So either you can turn down the heat so it doesn't boil over, or you could put a lid on the pot and a rock on top of that to try to stop it from boiling over. Well, you can sort of imagine how that's going to work. And, when Nixon introduced wage and price controls in the early 1970s, he finally realized these are not working because we have shortages and gas lines and all sorts of distortions in the market. He had to let them go. And then what happened to inflation? Boom, it shot up, 20%. And so you have to work with markets, even in the health sector, where most of it is not based upon market principles, which is really the problem. And so we're trying to figure out, how do you get people to see the value of innovation? How can we get out of this by turning down the heat and allowing innovation to continue and not have it so completely suffocated with a rock on top of the lid of innovation as we do with regulatory policy, payment policy, all of the laws and crazy distortions that politicians introduce into 1/5 of the economy representing the health sector. And it's having after ripple effects throughout the whole economy. So we have to fix this. But markets and consumer-centric and innovation, those are my 3 ideas.
Perfect. I love that you're giving pocket cards. I've met with a few, let's see, mainly candidates. For a bit, I wanted to just meet with anybody who's running for Congress or anybody who's running for a state representative in my area and just sit down with them and see if I can talk some sense into them. I met with each party,
Right.
and I think pocket card is generous. I would have gone with picture book personally.
I need to have grasp, but it's really hard to put the value of innovation in visuals, Maybe I'm a print person, so I need to have somebody that brings us into this.
Nothing will frighten you about the state of our government as much as sitting down and having a reasonably long talk about a specific issue with a representative, be it state or federal level. It's truly frightening how little these people actually know. And thank goodness we have actually good people who know things in their ear, like you and the Galen Institute. So awesome. Thank you on behalf of all of us. So how exactly do we get more innovation? Let's start with innovation.
So I want to show you the pocket cards. So Jake, here are the pocket cards. So as you see, so we got, 14 pocket cards. So take and choose. They're on this little cool thing called a carbon era, something like that. But, if a member of Congress just needs to talk about one particular thing, let me just pick one at random here. The dangers of foreign control, why we don't want to decimate our pharmaceutical industry and our research-based medical industry because the Chinese are really anxious to take over that. And we
Hmm.
would then cede the ability to have drugs that we consider to be quality with our FDA approval process, which needs to be reformed, and make sure that we don't wind up not killing this, according to Tomas Philipson, former Council of Economic Advisors chairman under the Trump administration, 139 fewer medicines over the life cycle of drug development because the drugs just aren't developed under the price controls of the Inflation Reduction Act. So we talk
Hmm.
about specifics of the legislation that Congress is considering, that it should consider, but we don't advocate for or against legislation. We just talk about policies and the ideas and what we expect to happen as a result of passage or not of these various bills.
Well, let me ask you a question about that because what's your view on how exactly we reward innovation in the drug space? Because currently, let's say I come out with let's say Busher Enterprises LLC, construction company, comes out, believe it or not, with an anti-cancer drug, right?
Mhm.
And very excited. Um, and I could apply to get a patent.
Mhm.
And once we get a patent, there's a sense in which patents are free market because they protect, property rights. But there's also a sense in which the time in which you have this exclusive right to sell is kind of arbitrary, and it's chosen. It's not necessarily subject to a market test. And then when you do go to sell that, well, now you have these monopoly profits. Normally, when we talk about monopoly profits, we call these rents, right? These are over and above what the market price would have had if there was competition. But wait, now we took away competition, but we kind of want to do that so that we reward innovation. So I mean, I've heard some people say maybe we need to replace that system with prizes, and some people have suggested that. The problem is prizes seem even more arbitrary, right? Like, who is to set the size of the prize? At least with the patent, the prize, if you will, is set by how much people actually want to purchase your drug, and that seems to match how much society deems it useful, or at least one would hope. Um, I mean, I have an idea I can run past you, but really, I want to hear your idea on that. How do we how do we do this? Is there a free market way to compensate these people according to what the value they've produced is? How do we do that?
Well, we actually have evidence of that in the Medicare Part D program, which was introduced, passed under President George W. Bush in 2003 and began working in 2006. And basically, what it says is the government believes that if you're on Medicare, you should have access to prescription drugs. Well, the majority of people did already through various programs, but they wanted to put it as a program within the Medicare program. Well, there were two different ways to think about doing that. One is to simply add prescription drugs to the Medicare payment formularies, of which there are many because of the different price structures in different reaches of the country, and have the government price control those drugs, or see if we could have a market that might work. And so they said, let's try to make a market. My former colleague, senior fellow emeritus at the Galen Institute, Doug Badger, was the senior health policy person in the White House, really helping to structure that program. He'd been steeped in health policy for years and really incredibly brilliant man. And he said, why don't we attach the subsidy for the drug benefit to the individual? And they can use that to shop for a drug plan that
Mm-hmm.
provides the best and meets their needs. And this was a whole new industry, right? Prescription drug plans didn't exist as a freestanding product. And so they said, let's see what happens. Well, they were surprised when so many companies came forward to offer a prescription drug benefit. And then they started competing with the
Mm-hmm.
federal government. There's a role for government. We have to make sure it's a real drug benefit. 150 drug categories with at least 2 drugs in every category, and that can be updated over time. That's what you have to offer. But which 2 drugs those are is really up to you. How can you negotiate the best discount? And so what would happen was people are able to see all the drugs that are covered by brand name in those prescription drug plans, and then they can decide which one they want. And the competition was fierce. Humana, for example, came out with a prescription drug plan whose premium was $1.87 a month, which is really
Okay.
nobody expected that. But it's because they were competing. They wanted to get people to sign up with Humana because then they thought, well, maybe if we could get them with the drug benefit, we could incorporate the drug benefit into their overall Humana Medicare Advantage plan, which is the basically the private health plan option in Medicare, and then we can get them to join our Medicare Advantage plan. And it absolutely worked. It was really quite remarkable. And you now see, I mean, over how long has this been now that it's been in effect? 18 years, that politicians just cannot help but really try to meddle and to try to change this. And a lot of the changes that the Biden administration has made, a lot of them by just stroke of the pen saying, we want to decide that you're going to have to change the catastrophic deductible and the plans are going to be responsible for much more of the cost. Well, what happened? Premiums are soaring because they basically said, we're not going to give you any more money, but you have to cover a lot more benefits. And so they said, well, we have to increase our premium. Well, those premium announcements are going to come out in October, which in a presidential election year is not really a very good thing. So what do? They decide to have a demonstration project to say, well, let's just see if we were to provide extra subsidies to the drug plans, if they might be able to lower their premiums for seniors. Well, of course they are. And so it's just putting another rock on top of that boiling pot, right? That they're not solving the problem. They're putting more fuel into the fire of inflation and high prices and basically trying to contain it with more taxpayer spending. It's not going to last, but that's their plan, and that's their.
Gosh, yeah, price controls. It's like the flat earthism of economics, in my opinion.
Yeah, right.
And even most decent liberal economists, if you sit them down, shake them and say, all right, be straight with me here. What's going to happen if we cap the price below the natural point of equilibrium? They'll go, don't tell my friends, but there's going to be a shortage. It's like, yes. You read the textbooks, you know.
Higher prices.
Yeah. So people are fully aware of what ought to happen here. I recently saw an article by a couple liberal sources, including Axios, discussing some of Harris's economic ideas. And they straight up said, even liberal economists believe these are bad ideas, but hey, we basically need it for the votes. Just come right out with it, don't you? But, you highlighted something interesting and getting a bit off track here, but and that's the role of the insurance companies, where they're commonly demonized. But I mean, I checked what the net profit margin for Anthem is. It's 6% in 2023. Right? And they do perform a vital function. What you were describing there is there's a lot of, there's an information problem for the regular consumer. Like, they can know what drugs they might need, but they might not know the drugs that they might need in the future. And they don't know how to assess the quality of all of these. So we have an information asymmetry problem. So a third party, a middleman, is what's needed here to be able to do the negotiation for a group in order to ensure that the quality of the things is going to be high and to seek out value in the marketplace. And then it's a much simpler job when it's the consumer. They simply look at, does this give me the things which I know I need? And is the price attractive? And should I respond to this price or that price? And they know how to choose between those. Which one's lower? If it meets my quality standards and it's cheaper, hey, it's delivering me more value. So having that intermediate, player, the insurance company, these guys are seeking out value. They're putting pressure on hospitals, on drug companies in order to deliver the best value for their customers in a way that customers might be challenged in doing on their own.
And the value of competition, because Humana knows that Aetna and United and everybody else is trying to do the same thing to
Hmm.
those consumers. And so they all have to say, we want to make sure we're providing the lowest price and the highest quality, which is what you want in our health sector, which is what we have far too little of. But it worked for a long time in the Medicare Part D program, where premiums were basically level for 10, 12 years
Wow.
until politicians started meddling with this. And then we see these price hikes when they have to, continue to say, oh, how do we stop this? Well, let's throw more taxpayer dollars into the equation, which will only make it worse and make it worse for the next person that has the next president who has to solve it. So you're absolutely right that this is not a solution. And unless we get markets to work, and the only way you get markets to work is with transparency and incentives. And there is a role for government, saying that every plan has to cover 150 different categories, because the senior may be on, blood pressure medicines and, whatever diabetic medicines, but they don't know they're going to get cancer. So you need to make
Hmm.
sure those drugs are covered as well. And so you've got to have the fuller panoply of drugs that are available to them, but let them choose the plan that's provided the specific brand name they want. And that gets back to something you said earlier that I think is important. When you look at competition and patents, and yes, they can have a patent for 20 years for a new drug, a new molecular entity, but that doesn't stop another company from coming up with a slightly different molecular entity for the same problem. We've seen it with the weight loss drugs. We saw it with hepatitis C, where somebody comes out and it becomes a real blockbuster, and other companies have been working on the same problem. They get theirs approved, and then prices go down, sometimes down to a third of the initial release. We've got a pocket card on that too, that you've got to really see that the drugs are covered, but you get competition in the market by allowing the market to compete for that drug category, even if they're not allowing them to seize the patent, which would totally discourage investors from investing in that product. So you've got to have patent exclusivity, but that doesn't mean you can't have competition in that category of the particular problem they're trying to solve. And as I said, we see it a lot with all the different drugs for weight loss that are coming to the market.
Okay, yeah, I like that. I like that response. So it's not that they actually truly have a monopoly, because there's more than one way to skin a cat, right? And that encourages a variety of solutions to the same problem, and then these various solutions can then compete. That's interesting. I want to run a half-baked idea past you since you're
Well, how do you
since you're here.
do it?
And this one's not one that I'm tied to, so feel free to throw rocks as rocks are necessary. Well, what would you say if we said, okay, we're going to eliminate the patent system for these new drugs, and here's how we'll do it instead. You create a new drug, and then you can license it, and you can there's only, say, 3 licenses available. At which point these get auctioned off in the market, and then other drug companies can say, I want to be able to license it immediately, and you have to set the price such that we get 3 competitors in the market. So it's going to be low enough to get 3, but you can keep it high enough so that you only get 3. At which point they're compensated based on how much a market of competing groups would be able to sell it for, but they get the advantage of they can manufacture it first immediately, and B, without having themselves to purchase one of the licenses because they own one from the onset. So
Yeah.
if it's something that people would see would be incredibly valuable to be able to offer as a company, then they'd be willing to bid that up a whole bunch to be one of the ones to offer, say, a generic. So to me, that seems like it's putting it to the market. Do you want to have the right to manufacture and sell this? And then we get a market price. We get at least a couple of suppliers, not many. 3 is not many. That way we don't have to, it seems arbitrary to say it's a 20-year patent. Maybe we do patents for 3 years. Maybe we do it for this. Maybe we do it for that. And then, although there's multiple ways to, say, fix the same problem of, I don't know, they're dealing with all these obesity drugs. Well, maybe there's not. Maybe there's only one pathway that really needs to be changed with this specific drug. Maybe there's only one way, or one easy way, one effective, one safe way, and this would allow competition in general. So that's the half-baked idea. I give it to you for
I would love to get a room full of economists to really hash this out and figure out where would this go. But my non-economist, but sort of reading for economics view, is that whenever you get a new system in which politicians get to pick winners and losers, which is really what they do, and it's not necessarily going to be based upon merit. It's very likely to be based upon how helpful you can be to that politician, that you're going to wind up with real distortions in the market. And we look at, for example, the psychotropic market. There are a lot of drugs for many efforts to try to come up with drugs for Parkinson's and schizophrenia, bipolar, and all that. And there is a great deal of competition in those markets, but they also are competing to make their drug work best for some subset of the population that may have particularly adverse reactions to one of those drugs, or one that says, this is the only version of this drug that works for me. So you really want to have a whole lot of choices, because then otherwise, if you have politicians deciding only 3, then you're not allowing the consumers to be able to say, but within this, this category of drugs for bipolar, this is the only one that works for me. There may be 20 in that market, but I need this particular one. So you still need competition, not just for the disease or ailment that they're trying to treat, but also for what the side effects are, what the dosage is, the ease of taking it, the administration of it. There are a lot of different aspects that are important to patients that might not be important to politicians, and that would be lost. And actually, one of the things we're seeing already with the Inflation Reduction Act, so misnamed, but that's what it is, that is putting price controls on the best-selling drugs in Medicare, is that investors are pulling out. And we see research scientists losing their jobs in major pharmaceutical companies because they have to pull a drug from the research table. There's no way that once this drug comes to market, we would be able to have a return on our investment when the government's going to set artificially low prices. So,
Right.
and I think it's probably easier to see in something like Kamala Harris's idea to, basically stop price gouging at the grocery store. Well, you think it through. Okay, well, eggs cost, what are they now? $6 a dozen. They should not cost more than $4 a dozen. Well, but when you look back, the grocery store is paying $5.50 to buy those eggs and still only have a 50-cent, maybe even 25-cent profit. And grocery stores have a 1 or 2% profit. I mean, they're already at the wire. And you tell them they have to sell eggs at a loss. Okay, well, then they're going to raise the price on something else, right? There's no price control.
Exactly.
And so it just goes down the line. Why are producer prices high? Because of transportation costs, because of fuel, because of fertilizer, because of labor costs. All of those are rising. Just because you want $6 eggs, how do you get all of those other higher costs out of that carton of eggs? You only can do it by saying, let's figure out why those prices are high and figure out what we can do to lower fuel costs, to have more competition in the market, to have more, to have the ability of producers to innovate so that they can figure out how can we get more eggs per chicken with that still have them be high quality. All of the things that producers compete on. You need that competition because the market is going to figure it out, not politicians.
It's so funny that people, suggest greed. Greed has caused the price to go up. It's like, guys, you do know that greed is kind of the natural state of humanity. So you explained a change based on something which has been the same since the dawn of humanity. That's about the dumbest way to explain it. So no, it's not greed. It's so funny that greed always seems to arise as soon as, I don't know, the quantity of currency rises quickly. Or this greed just magically shows up as quick as we increase the cost for producers with burdensome regulations. It's amazing. The greed seems perfectly correlated.
Well,
But
and greed is just another name for you have to operate in your self-interest. I mean, why does somebody decide to be a cobbler or, 200 years ago, or to open a general store or to become a physician? It's because they have a particular expertise or skills or tools or,
Mhm.
a seamstress to be able to produce something that they think they could do more cheaply, more efficiently than if somebody were to do it themselves. And so then they trade their expertise for the goods. Sometimes it was good. Sometimes you got a chicken or whatever you did. But, for some sort of tangible reward, and you have an incentive to develop your expertise, to get better at it, to be able to get the production costs lower in order to be able to get more business. So if we look at the basic incentives in the health sector, all of that has gone out the window. Mark
Mhm.
Pauly, who's a sort of the dean of the health policy community, emeritus professor at the Wharton School, University of Pennsylvania, Pauly, has basically said that we don't have a free market in the health sector. And of course, the other side says, oh, we've got this unfettered free market. Are you
Oh,
kidding?
yes, their lips to God's ears. I wish we had a free market in
Yeah,
healthcare.
right. But everything in Medicare, which covers 63 some million Americans, is totally price controls.
Mhm.
In
Mhm.
Medicaid, which covers 80 to 90 million Americans, absolutely price control, both federal and state levels. So you have even the private sector with employer-provided health insurance covers 150 million Americans. That even is under government restrictions of what kind of plans can be offered, how it have to be pre-existing condition, all the stuff that government has decided are important, that you have almost no free market in the health sector. And when you do, it works. The
Mhm.
Surgery Center of Oklahoma is a perfect example where here are this group of physicians that operate a physician-owned hospital, which Obamacare made illegal to start any new one. And these are happy doctors. They get to hire the nurses. They get to get the equipment that they want. They provide the ideally best surgery often for various knee replacements and any mostly elective surgeries,
Yep.
and at a lower price.
Yep.
And so you could see in these little baby pockets, with the Medicare Part D's prescription drug benefit, with the Surgery Center of Oklahoma, physician-owned hospitals. Plastic surgery is another thing that's not very heavily regulated, and its prices continue to go down.
LASIK.
LASIK, yeah. Whenever we have an example in the health sector of a market where consumers actually get to use their money to be able to make a choice, that you wind up with a better solution. Now, there are going to be people who don't have money. And yes, we want to support the most vulnerable. We want to help people who don't have the ability to get health insurance on their own. But that doesn't mean we have to regulate the entire $4.5 trillion annual expenditure in healthcare from Washington or state capitals.
Absolutely. Absolutely. And, those physician-owned hospitals, some empirical research showed that not only is their quality commonly fantastic, but in aggregate, when you look at um, intervention to intervention, they're about a third cheaper. So yes, they've been outlawed. These have been outlawed, which is ridiculous. There are some which are grandfathered in, which are still able to operate. But the idea that we should stop doctors from opening up hospitals to do what they're best at is absolute insanity. So we talked a little bit about drugs, and it sounds like we had things going decently until, of course, the government jumps in and begins subsidizing things, begins regulating things. The government has two modes, it seems. One, reduce supply, and two, subsidize demand. That seems to always be their go-to move, when in fact, that's exactly the wrong thing. We want much health care, and we want people paying their own money for it to the extent that that's possible so that they actually seek out value. And it doesn't just run amok. But still, we have prescription drugs as a percentage of the ridiculous amount of healthcare spending. What, 17 point something percent of all of GDP is spent on healthcare. Still, drugs are only, what is it, about 10% of healthcare spending.
Correct.
It seems to be its majority hospitals and other types of expenses. So what's going on with that? I mean, if you look at take-home wages for Americans, because employers are on the hook to provide full-time employees with healthcare coverage, it's basically stagnated take-home wages for like a couple decades, especially relative to the gains in productivity. It's been, what Warren Buffett described it as the tapeworm of American economic competitiveness. Our healthcare system. So the main driver of this cost seems to be hospitals and whatnot. I'm using hospitals just to describe any place where you're receiving that type of care. Obviously, we've made a law which makes doctors not able to provide these. We've made it incredibly difficult for free clinics, which is something that's often ignored, and that is insane. What other changes have happened? I know the quantity of hospital beds per 1,000 people has dropped off a cliff since 1970. We've had those nutcases over at the AMA advocating for reducing the quantity of doctors, and that's kind of come to full flower. What are the big problems? What are the big rocks in the biggest chunk of spending that we could fix?
Not adding any more price controls to the system, I think, is a good start. And I think the example of eggs at grocery stores is amplified many, many times in the health sector, where here's how much Medicare will pay for a heart coronary bypass. This is what we're gonna pay you, and then private plans kind of use that as their basis and how much they're going to get discounts or whatever. So there's a huge game that goes on around the price control mechanisms that government has injected into our health sector. And the more they do it, the worse it gets. And we look at the housing market now with Kamala Harris saying we're going to provide $25,000 to first-time home buyers to be able to buy a house. What's that going to do, Jake, to the price of housing?
Surprise, surprise, because we have a low elasticity of supply, in part because of ridiculous zoning policy, which limits the quantity of new housing that can come onto the market. Wow. Well, that's going to be split a tiny bit to the buyer, but majority to people like me. So that $25,000 is going to go to drive up the cost of housing. It's not going to drive it down. And if you actually wanted to drive it down, you should actually move the supply line up a little bit, and you'll see prices fall. You'll see an expanding sector that can employ a variety of Americans, even those without college-educated degrees. And the world would be a better place. So no subsidies, particularly in a market with a supply which can't respond and respond quickly, is a stupid policy in any possible meaning of that term. And I think anybody who actually knows anything about economics knows that perfectly well. And what disturbs me most is that it's politicians who are pushing this, and even some of them know what's going on because it's popular and gets votes. It sounds good, not because it actually does good.
Well, and you point out the problem about supply and demand, and so then they have another solution. Okay, we're going to federalize a zoning law. Now, really, how is that going to work out? I mean, does Maine and Montana and Mississippi and New Mexico, there are very different considerations in why they have zoning policies, or Houston, which apparently has almost no zoning policy. The federal government's going to come in and get into the hardwiring of a zoning policy in a community, but that's their solution. And the other solution is the federal government is going to build 3 million houses to increase the supply. And then we can say, well, how did that really work out with EV charging stations where they got billions of dollars to build? I don't know how many we're going to build, EV stations. How many have they built so far? 7. I mean, why do they say that is? It's because, oh my goodness, you get into all these zoning issues and all of these, complexities. Okay, well, the federal government's going to take that over. When on earth has the federal government ever made anything simpler? No, it makes it more complex and more difficult. And we see every day in the Federal Register, thousands and thousands of new pages of regulation that the industry has to comply with. Doug Holtz-Eakin, American Action Forum, who you should have on. He's really great. But has a running list of the newest regulations and how much they're costing the economy. And at some point, we reach the breaking point that more regulation. The federal government, what's the question? The federal government is almost never the answer.
Absolutely. Absolutely. All the way back in the 1920s, before there was near as much government regulation, I have heard tell from some healthcare economists that a very common way that this whole health thing was solved was, let's say I'm a cardiologist and you're a oncologist or something. We'll team up and we'll be like, all right, you got cancer, I got heart stuff. We're going to grab a bunch of other people and we make a little group. And then we advertise to people and say, hey, we can keep you healthy. All right. You got to take some of our recommendations. And if you don't, we might turn up the monthly cost. But in return, if you get sick, it's on us and we'll get you well. So what we need you to do is pay us a monthly amount and we are the insurers now. So now if anything goes wrong, it's on us. So we want to limit that type of cost, right? Because now it's not just the insurance company trying to somehow monitor what on earth is going on in the hospitals. It's actually, in a sense, the hospital monitoring that itself, not getting an incentive for additional care, but that's actually a cost to it to provide additional care. You're being paid to be healthy, not compensated by tax dollars to, find why people are sick and need more tests. And that seemed to be quite effective. And you notice that's something that happens at a very small scale, right? We could get a couple physicians together and they could offer that almost immediately. And if we weren't regulated to up the wazoo, this would be something very practical. And I think that would meet a lot of people's needs. But when you put that into the federal hands, they're going to have requirements which require a scale which is entirely unnecessary, because that's what happens with these regulations and taxes and whatnot. In order to comply, this entails a cost. And in order to be able to pay that cost, since it's fixed, you require a very large scale. And as you scale up, you lose that type of granular information, which is only possible at the level of purchase. As you lose that information, you're less able to care for others. So regulation is the problem. I know people believe that regulation must always be from on high and in a wonderful pro-consumer way, but that's not always the case. There's unintended consequences.
Yeah, because consumers know what they need more than the federal government does. And just to take what you're talking about in another level, the physicians who most exemplify the example you gave about a physician who's going to get a monthly fee to keep someone healthy are the direct primary care physicians. And they're the only happy doctors I know. And these are the ones who've said, we're not doing insurance. Pay us, I don't know, $50, $60 a month, whatever they charge, at various fees. You can call me anytime. Here's my cell number. I can buy generic drugs at cost. And so you need a prescription. I'm a physician. I can help you with these drugs for nothing. It's part of your fee. And that's that example, talking about 10% of all health expenditures is prescription drugs. 85, 90% are generics, where there's huge competition in the market. It's the brand name drugs that are highly regulated that are wind up being the major driver of some costs. And so what are we talking about? We're talking about 1% of the spending in our health sector that is the complete focus of what we need to do in the health sector. And it's the more government gets involved in it, the more it gets fouled up. And so we really have to figure out, how do we get the market working right in the prescription drugs and the health sector overall. Now I forgot what I was going to say about what.
Well, I could jump in with something.
But direct primary
Oh,
care
go ahead.
but the direct primary care physicians, and now I remember, also say you really have to have a catastrophic health insurance policy because I can't know if you're going to get cancer. And that may be something that started when you were serving in the military and were fueling jet airplanes and then gave you these toxins in your system that only 20 years later are showing up as bladder cancer. And so
Right.
the doctor can't help that. But you do need to make sure that that person can get care if they need it. And that means a catastrophic health insurance policy. So I think pairing doctors who really are there to take care of the patient with catastrophic insurance to cover them for unexpected health outcomes that the doctor really, plus so much of health is dependent upon how we eat, how we take care of ourselves, what we ingest and what we don't ingest. So you really have to be to help them do better at taking care of their own health. There's only so much you can do, but so that's why you need the catastrophic health insurance and somebody who's kind of on your side to not only help you to learn how to have better health habits, but if you get sick, okay, well, I've got a network of doctors that I know in the oncology sector, and I can get you an appointment right away. And then I will talk with them and go with you through the process. So you've got an advocate, a physician advocate for you.
Perfect. What that sounds like is a scale that doesn't require near as much administrative bloat.
They don't have to do all the paperwork. There's nobody they report it to other than their patient.
So I found out that 1/3 of let's see, it was an article by David Cutler, who is wrong about a lot of things, but he does have an interesting. He's the
right spot.
Yeah, he's like, oh, it's greed, but somewhere in there, points out that Germany and Switzerland have half the admin cost that the U.S. has, and that admin makes up something like 1/3 of healthcare spending, like not in aggregate, but that relates to, say, hospitals and other like care providers like that. About 1/3 of that cost is their admin, and half of that seems to be unnecessary because other companies who do have, private insurance and whatnot and have to deal with a lot of the same stuff that we do, well, they can do it for way cheaper. So why on earth is admin so expensive? So the cost of administrative staff over and above what similar countries have is more than all of doctors' salaries combined, right? Because that makes up about 9%, 10% of healthcare spending. Is more than all of pharmaceuticals costs. That's what 10 something percent. This is a huge fraud. Why on earth do we have so much administrative bloat? Just more complexity? What's going on?
These hundreds of thousands of pages of regulation. The Americans, I've done a lot of speaking in Europe. In fact, I have a couple of talks this fall. And the thing I've concluded is that the culture of the country determines the kind of healthcare system you have. In Europe, Germany, the idea is solidarity. We are all in this together. And that's sort of the European sort of socialist mentality, is that solidarity. In Canada, a government-run healthcare system run by provinces as well. But they're basically saying, I will wait in this line for 2 years in order to get the treatment I need because I don't want to jump the line in solidarity with my fellow Canadians. Well, guess what? Americans aren't like that. The fundamental principle in America is freedom. And we heard that throughout the Democratic nominating convention last week, where they were talking about freedom, freedom, freedom. That is a fundamental driving force. But with that comes distrust. We don't trust government. And so if a doctor is going to provide a service, we want to make sure you actually provided that service. And we have a document that says that you signed this, that you provided the service. And if you didn't, we can come after you. We also are a very litigious society. And so we drive these administrative costs because we don't trust doctors. And, the person who's paying a monthly fee to their direct primary care physician, doesn't need any paperwork.
Right.
Does the doctor answer the phone? Am I able to get, the prescription for my child's ear infection? What they know they're getting the services that they're paying for. But when you have a third party payment system, and that's overriding the problem in our health sector, is it you've got one person as the consumer, another person as the provider, I hate that word, and then another person is the payer. And so the payer has to, look over all this. The consumer is just basically the the cog in the system that you have somebody that you're doing something to get paid, but then you have to have all of this other bureaucratic paperwork to document what you have done and to report it to whatever entity it is that it's paying it. And you see it now with this prescription drug benefit that we talked about earlier. One of the things that the prescription drug plans are saying they're going to have to do with all these new requirements is have even more reporting on whether or not this patient really needs this prescription drug. You have to go through the approval process. And at some point, doctors give up. And that's exactly what they want. This is an expensive drug. We just as soon not provide it. So let's make it really hard for the doctor to get that for the preparation. And they're going to do even more of it. And that's where the administrative costs come.
Gotcha. So what do you think about Singapore? You mentioned that you've kind of looked at a lot of the international systems, and they lean hard on HSAs.
How savings accounts.
And that allows people to spend their own money. I mean, if you have somebody else spending money for your benefit, then you care about quality. You don't care about cost, right? Like, you paid your premium. All right, you're done, right? Now, whatever costs that you shift over to your insurance company, well, that's their problem. So it seems to incentivize in our system quality, but not necessarily low prices. And then they, as third parties, try their best to kind of look over what's going on and try to not make consumers so mad by, denying coverage for certain things that they get some competitor coming in and stealing the lunch. But they don't want to spend so much on looking over what's going on in hospitals that it's not worth the monitoring cost. They're kind of in a pickle, right? They're kind of caught in between, trying to be the only price conscious people in this whole system, because basically the consumers aren't anymore. Yes, there's co-pays and whatnot, but we've certainly blunted the effect of the high prices when people don't directly spend their own money.
Right.
So with healthcare savings accounts, what kind of traction do you see in the U.S. for doing a more Singapore-like system where we lean on this, allow people to spend their own money? Maybe in lieu of Medicare and Medicaid, we can give people the cash value in an HSA, and then we can have price-conscious consumers. I've seen some data that we only need about 10% of people in a market that are price-conscious to steer the entire market towards something that approximates a market price. So we don't actually need everybody to do it. We just need a core group of people who are really seeking value, and the market can then deliver that, because it needs the information from people buying and selling things, and it doesn't have that. So what's the pushback? Do you like this system? I'm not 100% on Singapore, but it certainly seems better than what a lot of other nations are currently implementing. I know that was a big question.
Yeah, well, it's also, Singapore has its own culture too. I mean, it's a very, people are very regulated. They're required to clean their tires of their wheels of their automobiles so that the roads stay nice and clean. So the payments and the balances that they each have in their health savings account is required. This is something that's what we would have considered the individual mandate. You have to have a certain amount of your salary that goes into these health savings accounts. People are afraid to spend it because they see that as their insurance, as their security. That if they get sick, then they will have the money there to pay for it, because they don't trust that the government is going to be able to make up the difference. And so people just have just as much anxiety as Americans do about their health savings accounts. They don't want to spend the money. And so that often means also that they don't get the care that they may need because they don't want to part with that. So I don't know that there's a really perfect system. The only perfect system is the system that works for an individual patient. And what that means is you have to have a plethora of choices and options. Some people, when I've had many staffers working for me, and some of them, they only wanted an HMO. They did not want, a fee-for-service plan. Another one would only accept a health policy that had a health savings account with it because she was a real saver. Others, I don't want to think about this. Just give me a health plan, and if I get sick, I'll use it. So I had 10 staffers at that time, and I couldn't come to a consensus about the kind of health plan that worked. This was before Obamacare made it illegal to basically say, okay, here's part of your salary. It's going to be a visible part, and you get to decide what kind of health plan you want. Obamacare made that illegal. But what we need is to have people know, and this gets back to an earlier point you made about people getting poorer and their wages not increasing because so much of their compensation package is devoted to their health insurance. $25,000 a year for an average family. If you have a job at a normal company and you get, I have this great insurance with my company, well, that's costing you $25,000 a year. You may not see it, and you may only see the part of the premium you pay, which may be only 20% of the premiums. But you've also got deductibles and co-pays and oftentimes restricted networks of who you can see. And maybe it's not your doctor that you choose. But with a big company, they make these aggregate decisions, and they try very hard to make it possible for people to have the plan that they want. But the only thing that's going to work is to say, here is how much we have been spending on your health insurance. The market will respond if they know there are a lot of people out there unhappy with their current coverage and that want something different, just like they did with the Medicare Part D benefit, the prescription drug benefit. The market will come forward with other options because they see the possibility of getting that $25,000 in order to make that customer happier. And so what we need is a lot more choices for people, that 20% that is lesser regulated, I'm not going to say unregulated, but lesser regulated, needs to be 50, 60, 70% of the market. And then we have a real market where consumers are making decisions about what they need. And that does not mean that when they are wheeled into an emergency room on a gurney, the doctor looks over at them and says, you really need an MRI, but, can you afford that? No, doctor, I can't afford that. And just do the x-ray and we'll see if that's enough. That's not what you want. You want patients to be able to say, I've got insurance. I'm buying insurance to cover me if that happens, so I don't have to make those decisions. You want insurance for the big stuff, so doctors and patients are in charge, and not some bureaucrat in Washington. And that's
wasn't it under Reagan? Correct me if I'm wrong. I don't know. I wasn't alive during Reagan, but there was a deal struck that if healthcare providers, found somebody who couldn't pay for important care, then they would provide that care just for them. And in exchange, they were exempted from, I don't even remember how many taxes. It was pretty much everything. Like, you guys get to be tax-free in pretty much every possible way. But in exchange, you have to promise to take care of these people. And it's like that was done. And ever since, they've come hat in hand. We care for the people who can't care for themselves. And they seem to be able to bring this fact up time and time again to get subsidies, to get tax breaks, to get, you name it. It's always something that they're offering. But it seems like they already got something in return for that. They have to take care of for people you must provide life-saving care. That's part of the Hippocratic Oath too. But I mean, I feel like most people aren't aware. They really do think that if we don't provide some type of government insurance for people, then they could just be wheeled right back out of the emergency street and just dumped on the car.
Well, and that's what Europeans think. They think that somebody can't pay for something themselves in this country, that they just die on the curb. And I'm saying, well, why is it exactly we don't see very many pictures of that on the evening news? Because
Hmm.
it doesn't. And what you're talking about, I think, is EMTALA, Emergency Medical Treatment and something or other Act, that was passed that basically said if somebody shows up in a hospital and they need care, that hospital must provide care for that patient, whether they can pay or not. And so that was it was part of some other tax act. And it didn't seem like a big deal at the time. Well, what did that mean? Now we have to have payments to those hospitals, dish payments, disproportionate insurance. Basically, you have a disproportionate share of uninsured people. And therefore, we're going to give you a monthly annual payment to this hospital to compensate for the fact that you're having to treat all of these people who don't have health insurance. Well, then we pass Obamacare. It basically says everybody has an option to get health insurance, whether most of them are through Medicaid, but at least you have the option of getting health insurance. Well, did that stop the dish payments? No, not at all. We still need those dish payments.
Uh-huh. Yep.
So you wind up with a government passing some new law. There was a law and a regulation that basically says hospitals have to do X and we will pay you Y in order to do it. And then we pass Z, Obamacare, saying basically you shouldn't have any uninsured patients because you can even sign them up in the hospital if you need to. Well, we still need the dish payment. And so once you get a funding stream going from Washington,
It doesn't stop.
it doesn't help, even if the problem is very different.
Hmm. So I'm going to ask kind of an in the weeds question here. That is, there's the, what do you call it? It's the cost to, what am I thinking of? The cost, basically the expense of the hospital to the charge that they do ratio that hospitals talk about.
The loss ratio.
Yeah, so it used to be in like 1970 or so. That ratio was published at like 70%, where they said if we charge $1, it costs us about 70% in direct cost to provide it. And it has just fallen off a cliff to the point where it's like 20 something percent. And I looked up HCA, so the giant hospital company, publicly traded, and in their investor relations section they published their number, and it was 10.5%. So they're saying that for every dollar in charge, there you go, the charge to cost ratio, it only costs them 10.5 cents. Now, doctors I've talked to say, right, but don't worry too much because it's all made up. Right? The charge that they're talking about is not really the real charge. What they do is they come up with these incredibly massive inflated prices, and then nobody really pays them necessarily. Instead, they use that as a bargaining chip against insurance companies, governments, people who come in to pay with cash, and they say, hey, Anthem, we'll give you a 50% markdown.
That's right.
That was never the price. It's like when you go to a discount store and everything's always discounted. To me, well, first, I kind of want to find out how exactly did that happen, and why has it been declining? How come there wasn't? I mean, what's moved that? It seems like there's always been the same incentive to just mark things up and discount it down. Are we just on an endless trajectory? At some point we're going to have a 100-to-1 ratio? And the second thing that I find disturbing is when they come to the government and they claim that they've been giving care to people who can't pay, it seems that they would be using this as their price. They're saying, we provided $10 million worth of care to people who couldn't pay because that's the retail price that we made up. And now we're going to need what? A dish payment? Or would it be a tax break? Or what exactly are they asking for in light of that ridiculously marked up payment? Whatever seems to be going on, I don't entirely understand. I'd imagine you probably do.
Oh,
I want to hear what on earth happened. What on earth happened that this is the way it works?
Basically saying administrative costs are too high. We want to make sure you bring out the administrative costs in your And I think it's an insurer, um, if you're a big insurer and you have more than 10% in administrative costs, you have to rebate the difference back to the consumer. And so
Mm-hmm.
if you're on an Obamacare plan, you're going to get a check, every year if your plan was 10.5% rather than 10% in its administrative costs, that that compensates you, and they do not want to do that, right? And so there are all sorts of MBAs and lawyers and everybody else trying to figure out how to get that percentage within the margins of acceptability. It's 15%, I think, for smaller plans. So it's between 10 and 15%. But now that's become the industry standard, right?
And you know what's funny about that is people have looked at what the cost of administration in Medicare and Medicaid are,
Yeah.
and it's kind of difficult to get an idea for what's going on because their collection service is the IRS, so they're piggybacking on something else. But I've seen numbers as high as 20%. So if the government version of these insurance companies was a private one, they would either be shut down or they would be forced to pay out to their consumers that penalty because their own administrative costs are so much higher than what the private sector is already doing and doing by law.
And they do all sorts of things to mask that as well. Like you say, they don't build into that the fact that the IRS collects
Mhm.
your Medicare taxes. That there are all sorts of other agencies that are providing services to Medicare that they're not building into that administrative cost. And of course, government's not going to be more efficient, right? So you've got to figure out how you're going to have the market respond to consumer demands for lower costs. And one of the things that they would do is say, these rules and regulations that we're having to operate under are completely counterproductive. They're not helping the consumer. They're not helping doctors. We're losing good doctors because they have just added with the paperwork burdens that they have. And we
Mhm.
have to figure out how we're going to operate more like the Surgery Center of Oklahoma or a LASIK center, where the consumer is coming in and we have to answer to the consumer. And we have lots of health policy proposals because when it really gets down to it, when you talk about what do, we figure out how to adjust the incentives in payment policies to get the right outcomes instead of just throwing more taxpayer money at the solution or more programs or more restrictions or more regulations. That's never going to be the solution. The consumer is king, but not in healthcare. And we have
Mhm.
to that.
And doctors are kind of forgotten about in this. I think it's Pew Research. It might have been someone else did a survey and found out that doctors, in large part, some of them are happy, but the majority of them aren't. In fact, when they asked, I believe it was within the last year, have you contemplated suicide? And 14% said yes. So this is not okay. One, we've put this massive regulatory burden on them. We've put these paperwork regulations, which are out of control. And next up, we have a fairly old population. We have people who, um, use our healthcare services a lot, and yet our total number of doctors is not what it used to be. It's declined, and in large part because of the advocacy of the AMA.
Wow.
Um, as I understand it, there's a Medicare funding for new residents. So, and it's just not economically viable for hospitals, not all hospitals, so some do it, to fund their own residents. So when Medicare funds residency spaces, it means that schools can now place these students over in these places, and then we get new doctors, right? There was a belief a long time ago that we had too many doctors. So they decided to restrict the funding to reduce the number of residencies. I think that was under Clinton, under the balanced budget amendment, actually. Now, I think that clearly with the crazy high salaries doctors have, that kind of implies that the market's demanding more of them. We see that there are, rising wait times, et cetera. There's a lot of demand for this. What concerns me, though, is that the way to increase the supply of these doctors seems to be very not free market. The idea we should have a government program funding residency spots.
No.
I would imagine the market would have taken care of this. And if we needed more doctors, the spots would be funded because then they would get new doctors. Like, what has failed here that means that a large hospital or a hospital network doesn't just say, write up a contract that says, work with us for 10 years and we'll fund you through residency or something similar? Why isn't the market providing that type of service? And why does it seem like we need the government to subsidize that in order to get the doctors we need?
It's sort of like the dish payments in EMTALA. Once you get a program in place, they don't think anymore about how could we solve this. And
Okay.
certifications also wind up being attached to your medical residency, and approved medical residency is one that is supported through Medicare funds. And so they just don't even think about how could we get this doctor, which is really cheap labor, and be able to bill for all of the services that that doctor provides. But you see 10% of medical school graduates that cannot find a residency place, which means that, and every year that goes by before they get that placement means that they're more likely to take a job outside of being an actual clinician. And so we've got to fix the medical residency problem, and that's high on our list. But the market is broken in so many ways in the health sector, and that's another one where we're reducing the supply of doctors, and who knows whether the AMA is involved in this or not, but certainly supply and demand would indicate that their salaries are going to be higher if there are fewer new doctors.
Sure.
And so we're going to have fewer new doctors, even though most people, if you need to see a dermatologist, expect to wait 6 months to just get an appointment. I mean, there's such a demand for physicians, and yet we're curtailing the supply.
So what can we do in the interim? Like if all of a sudden, turns out the election just elected you as president, people didn't like the candidates, they decided let's do Grace Marie Turner, and you get to write up a solution that we could implement immediately to increase the supply of doctors. Right now, they're used to getting this just funded by the government. They think of these as good, safe, approved spots. It's a moneymaker. We have all the salaries have adjusted to the idea that the government will kick in basically your training costs for the first number of years. What would be your first step to transition from the nonsense we have now to something that would allow the market to match the quantity of doctors to what we actually are demanding?
I would bring in, again, I like meetings, right? So I think that you get a lot of smart people together in a room and you come up with ideas and solutions no one of them would have thought about. We need a study about figuring out what is wrong with the medical residency system that we have right now, and what is in the way of a hospital saying, I'm going to fund the residency myself. Does that mean that the residency is not going to be certified and that therefore the physician has lesser economic opportunities and doesn't want your residency? We need to find out what's the root of the problem. And then you saw, I have no magic wand here, but there is a magic wand if we get enough smart people in a room to figure out what's in the way and what regulations or what changes in policy do we need in order to be able to increase the supply of physicians, and let those 10% of medical graduates go on to, they've gone through all this in the first place. Let them complete their residency so they can be physicians. That's what they want to do. But we're keeping them from doing that. And there's a public policy problem in all that, and we have to solve it.
Okay. How are you doing on time over there? We can cover a couple more things if you like.
A couple more things. I had a 10:45 call, but I've sent her a note saying I'm going to be late, so don't worry.
Okay. Well, then let's just do one last thing and we'll wrap on up. International competition.
Yeah.
That's a big one, isn't it? But of course, we have a lot of talk with drugs, and you'd imagine the free market perspective is, it's cheaper in Canada, so why are we making it illegal to bring bulk drugs from Canada into the U.S.? But it's not quite that simple, right? Because they're actually paying prices which are pretty much subsidized by us worldwide, and you're welcome, rest of the world. So they're getting cheaper drugs than we are because we're already paying for it. So does it make sense for us to go and purchase it from them and arbitrage this away? Is that the free market solution? Do we need to go upstream of this problem and find out why they're getting basically a subsidy from the United States and solve that? What would you do? How do
So
we, and then I'll add one more thing is with the rise of telemedicine, it's not just drugs that can move over borders, but it's actually doctors too. I mean, there's no reason we couldn't have an Indian doctor who's perfectly competent, maybe at the very top of their game, providing certain services, even writing prescriptions, maybe if we change some regulation, for American consumers. So what do you think about that international competition?
Well, the term medical tourism used to be a lot hotter than it is right now. And I actually went to Guatemala, maybe now 10 years ago, and toured some hospitals and medical clinics. And they have a government-run healthcare system. And Lord forbid that that's where you have to get your medical care, because it was basically a room with a dirt floor and a nurse. You're not going to see a physician, and almost no supply of drugs. So nobody wants that. And so people who have means in Guatemala have basically set up a private hospital system is set up to respond to them. And so they are wanting American tourists to come to their unbelievably fully equipped facility. Well, the day I was there, they were getting a $1 million new medical, probably an MRI, some new diagnostic equipment. And it was state of the art. And so there are people out there that are outside the purview of all these rules and regulations and payment restrictions and the craziness of the U.S. healthcare system who want to respond with a solution. So it may not be in Guatemala, it may be offshore in Jamaica, but I think we're going to start to see that as people are just fed up with the American healthcare system. And since doctors can't create their own hospitals in this country unless they've already done it, that they'll go offshore. So I think you'll see that. But with the Canadian, with drug importation, basically saying we're going to re-import the drugs that Pfizer has sent to Canada for whatever. The Canadians don't want that because they know that Pfizer's going to restrict their supply. And if Americans go and buy it all up, they're not going to have the drugs they need. So the solution, as you say, is to go upstream. And actually, my advice to Donald Trump when he was getting ready to do that debate in June with Joe Biden, and a piece in the Wall Street Journal about this, was basically think about drug policy the way you did NATO. Europeans were not paying their fair share of defense costs. All of it is on the back of the Americans. The same thing is true with prescription drugs. We wind up paying almost all of the R&D costs. If we didn't do it, the drugs would not have been brought to market. It takes 12 years and $1 to $2, $3 billion to bring a new drug to market. That requires a big company with a lot of resources and ability to fund this forward. And so what we need to do is figure out, he should go to our NATO partners and say, okay, you're not going to get this deal on these drugs anymore because Americans are ticked off. They're sick and tired of paying the research costs so you can get cheaper drugs. And so Bernie Sanders can say, why does this drug only cost $5 in Canada when it costs $100 in the United States? It's because somebody's got to pay for the R&D costs and that 12 years of research and going through all of the hoops with the FDA. And that patent, by the way, your 20-year patent starts when you start the clinical trials, not when you get FDA approval. So it may be 12 years into your patent life before you actually sell your first drug. So then you only have 8 years to make it up. Well, what does that do to prices? It increases prices. So we had a different system of patents. So that gets to your question, but it needs to be one that still gives the investors certainty that they're going to be able to get a return on the dollar. But it all gets pushed to the American consumer and into 8 years of patent life. That's why drug prices are high in the United States. One reason.
Gotcha. Yeah. At one point, I got in contact with an Indian reservation, which is up in kind of Northern Virginia area, because a lot of people don't know, they're immune from a vast majority of these regulations. And you can also travel in. So I contacted them about purchasing some used MRI machines and whatnot, and saying, guys, listen, I'm not Native American, but you are, and you have a reservation, and you have a very high-priced market in the area. Just, I would suggest this would be a great thing for you to set up. A lot of these used machines go to, third world nations and whatnot. Buy them for cents on the dollar. Set it up where you're at. You can skip all of the certificate of need laws stuff. You can skip a vast majority of things, and we don't need medical tourism outside of the U.S. because there's an outside of the U.S. inside of the U.S.
True.
Indian reservations. So if we have any
reservations, I'm from New Mexico, so I'm very familiar with the Navajo reservations.
Oh.
And so they're little enclaves, really, in the United States. They're not very geographically widely located, but it doesn't matter, I think. Just so long as you have the ability to set up an MRI machine or set up your own hospital outside the purview of all the rules and crazy payment distortions that we have on our health sector, make some money on it. Did they your offer?
You think casinos make money? Like hospitals make more. This is 17% of our economy. I would love to see experimentation here because, boy, that would just tickle me pink if they all decided, you know what, we're going to have a raging free market system and we're going to show the rest of the nation what happens when we allow prices to do their thing, entrepreneurs to come in, we allow innovation, we're not doing price controls. And I think the world would be blown away with what type of innovation we could have on American soil. Just got the government out of the way.
But there's less incentive for the Native Americans to do this because they have the Indian healthcare system.
Oh, yes. Oh, goodness. Don't get me started on that.
In the country, but that's ours. And so they feel, and oftentimes they're actually freestanding hospitals with doctors that are salaried, and it is government-run healthcare, in spades. And so they're really not incentivized to create an alternative healthcare system that, since they already have Indian health.
Do it to make money, guys. You already have your own covered. But I'll probably got to let you go now. Thanks so much for joining me and giving us all this insight. Thank you so much for what you and the Institute do. Please continue to grab our politicians by their little heads and shake some sense into it to the extent that we're able. We certainly need some free markets so that people can learn best ways to actually serve one another, and we don't just take wild ham-handed government guesses.
So people can see our pocket cards on our website at gala.org and actually download them, so they're there for everybody. There's no copyright on this. Please take it, and the next time you go meet with a candidate or a politician, say, what we really need is more innovation. Price controls are not going to solve this.
Yeah, or just what great conversation starters. You're sitting on a bus or in a train. You could pull out your pocket cards and educate the person next to you. Sure, you're on a plane and they can't run away or change seats. What a perfect opportunity to spread some good economic information. Well, I hope we did that in the podcast today. Thanks again. Thanks for listening, whoever is listening. And let's get you to that next meeting, I guess.
It's a pleasure to talk with you. Thanks, Jake. Thanks for being so well informed.
Oh, I tried. Thanks. Bye.